All right. Well, as I said, thank you for joining us. The main point of discussion for today's meeting is the Behavioral Health Access report that was put together by Providence Core for Better Health Together. The report is finalized except for the executive summary, which is some of what we want to talk with you today. Lisa from Providence Core and Carly Hood-Oronic will be talking to us about what's in the report. But before we get started on that, I just wanted to mention a couple of announcements from Better Health Together. One is that we still have a couple of spots open for either the Spokane Falls Community College or Eastern Washington SUD certification program. We are funding a few providers to go through those certificate programs. So if you are interested in that for more information, or you have a provider you'd like to send through, contact Charisse Pope from our team. The other thing I wanted to share is that Better Health Together is working with Zipline, which is a tech place here in town, to create a behavioral health dashboard. And this is something that we have heard a lot from folks, that they just, particularly referring partners, wanting to know where is their capacity and how do I get in contact with folks. So the website that that Zipline is putting together for us will really act as a checkpoint for regional behavioral health and social determinants providers regarding key services, current availability, and organization contact information. Right now, Zipline is in the process of getting preliminary designs to us, but I wanted to share that little bit of background on this because we will probably be reaching out to some of you partners to take a look at those designs and help us weigh in and decide what would be useful to you and most user-friendly from a behavioral health provider perspective. So keep an eye out for that, and we may have more for you at our September meeting around that. I want to pause here to see if there are any questions about either of those items or any other announcements that our partners want to share at this point. Okay. Well, let's move on to our behavioral health access report then. Before I hand it over to Lisa, we have some discussion questions that we will be talking about after we go through data, what's in the report. So I'm going to post both those discussion questions and a copy of the full report in the chat for us. And with that, Lisa, I'm going to hand it over to you.
Great, thank you, Sarah. This is Lisa Angus. I'm with Providence Core, and we work with BHT on a range of projects, most of which are data related. And joining me this morning is Carly Hood-Oronic from Community Health Strategies, who, I'm sorry, my fault that we neglected to put your name on the slide that is on the report. Carly did the lion's share of the writing around this report, so we're very grateful for her help and good sense in putting this together. This group, and I'm not quite sure how consistently, how many of you on the call today were also at this meeting in June, but we did give an overview of the report at that time. So I'm just going to go over it at a high level, and this will be a recap for those of you who were part of the discussion in June. The goals of the report, essentially, this is funded out of surplus or unspent integrated managed care funds from BHT. As part of a sort of larger strategy to support increased behavioral health access in the region. And the idea was pretty simply to bring various pieces of data together to provide a little bit clearer or more holistic picture of behavioral health needs and access for the region, with the caveat that there's always data gaps and there's only, it will never be the full and complete and 100% accurate picture. And then the secondary goal of having put that information together and trying to connect some dots was to be able to inform and assist BHT and all of you and BHT strategic partners to consider what happens next. What are some options for either alignment or investment on BHT's part or someone else's part or other kinds of strategic action. That was the goal. Sorry, I'm jumping ahead. I think I just did that slide. Right. So the way the report is set up is there's sort of a regional overview at the beginning that talks at quite a high level through the data available on behavioral health needs among the population in BHT's region, behavioral health treatment or utilization of behavioral health services so far, and then some discussion around financing for behavioral health, like what level of spending is coming into behavioral health services in the region from a variety of sources, county level or state level and so on. And also some discussion around, obviously you all are pretty familiar with, there's been a whole range of behavioral health policy work in Washington state and other areas, but in Washington in particular recently, so there's some discussion of the sort of major policy timeline in the last 5 to 8 years, but the focus kind of on Medicaid and fully integrated managed care, but talking through some other policy changes as well. So there's that broad overview section. And then we had 3 focus sections, which came out of some discussion with a group of stakeholders, I think and hope, including some of this group in January, about which topics would be sort of most relevant and particularly most relevant to a report reflecting the BHT region and not sort of nationwide hot topics in behavioral health necessarily. And so those 3 topics that ended up being focus sections with a little more detailed data were looking at racial and ethnic inequities and access to behavioral health care, community behavioral health broadly, so sort of the behavioral health systems serving non-privately insured populations for the most part, and then a section around transportation needs and geographic access to care. And then in addition to those 3 focus sections, there's a whole bunch of appendices that have some other data that was relevant but too long to flip in the report, and a whole bunch of citations. So that's what the report looks like. So we had a chance to discuss a draft version with you all, or a subset of you all, in June, and people had a lot of good comments and feedback at that time, and some folks also sent some written comments afterwards. And we were able to address a good number of those. So some of the changes, if you happen to have read the June report, some of the changes you'll see in this version are a sort of elevated visibility around racial and ethnic health disparities. It had been a third of the focus sections, which is not the right message to send. So that one's sort of elevated, and we've added some data too around Indian Health Service and tribal ITU delivery system and culturally specific providers or culturally specific care. There's a little data in there now too around financing from IHS sources. We have beefed up some data and discussion around telehealth, because particularly for behavioral health, because that was a topic of feedback in June, and we're able to get some data on variation by county in broadband internet access, if that's relevant for telehealth. And then there's a bunch of other sort of shorter discussion bits or bits of data added in response to good ideas from this group, including data around workforce and prescribers in particular, a little bit of discussion around co-occurring disorders, and some, in some cases, some sort of state and other ACH comparison points before we just sort of talked about the BHT region specifically. Those are some of the updates, and then there's various narrative updates since June as well. And then on the next slide, you'll see there's just a couple things we flagged that great topics and suggestions that people brought up that we weren't able to address. So for instance, one was someone mentioned about, oh, right, if there's X level of estimated need, but how many of the people who have, for instance, a recorded mental health diagnosis or recorded SUD diagnosis or need actually want treatment versus or in treatment, and did we have any data on involuntary treatment? That's not something I know that exists in the world. It's not something we were able to access easily, and so we're able to add it to the report. There were some other suggestions too around distinguishing mental health versus the providers, particularly in Medicaid provider enrollment data, which we weren't able to do just because simply that's not how the data are collected. And there are a bunch of other data gaps in the report, many of which are called out that that we're not able to address. On the next slide. So as Sarah mentioned, the report is finalized at this point, except for the executive summary section, which has some highlighted sort of opportunities for the region that we pulled out, and there's 4 of them, and they're listed on this slide. And we're going to talk super briefly about each one, but at a high level, the reason we pulled these out, or the reason these were the ones that got pulled out, because there's numerous, important topics in the report, and numerous other topics that are important but don't show up in the report at all. We pulled these out based on a variety of factors. One was your input and discussion in June, and some of the written comments in follow-up to that discussion. Another reason was some of these in particular have a real strong alignment with BHT's priorities and strategic goals and priorities of the BHT board. Timing was another consideration. I mean, that one particularly comes into play around telehealth, but we wanted to highlight sort of continued work on telehealth and expanding access to behavioral health services by that route now, since it seems pretty timely. And then there were other reasons around, particularly related to the data actually in the report, or data gaps that for us brought a given topic sort of to the forefront. So these are the 4 kind of draft highlighted opportunities in the executive summary, and that's part of the discussion today, is to talk to you all about whether these ones feel right. Okay, sorry, Sarah, can you go to the next one? I'm just going to walk really quickly through 4 slides that just talk about each of those 4 opportunities. So the one about addressing inequity is obviously a huge one, and it requires a lot of work. One thing we're just highlighting on this slide is this chart is in the report. It's looking at among Medicaid enrollees who have a diagnosis in Medicaid records of a mental health need, what proportion of those people got treatment over a 12-month period. And this one just sort of highlights the fact that there's almost a 20% difference from the group, the racial and ethnic group is Hispanic at the top, proportion of those folks who got treatment, versus at the bottom, a portion of folks with an unknown race or ethnicity with a mental health diagnosis who receives treatment. And that's a pretty wide disparity. It's actually a larger disparity in BHT than almost every other ACH region in the state. So that's just one disparity to pull out. And there's obviously a ton of work to do around addressing disparity, and it ranges from systemic things, addressing systemic racism and oppression, and making culturally specific care and providers more available, diversifying the workforce. There's any number of steps that could be taken, and I know a lot of the collaboratives in the BHT region and a lot of providers are already working on this. So these opportunities are also not called out in the because nothing is happening. They are called out as opportunities for sort of continued and expanded action. So that's one of them. Next one is around behavioral health and telehealth access in particular. I think folks are fairly familiar with this since there's been a lot of discussion and expanded activity since COVID. One thing, and working on this or continuing to work on this could involve all sorts of things, making sure that some of the recent policy and reimbursement flexibilities stay in place to the extent possible given state budgets, continuing to look at regulations and reimbursement models to see where else they are sort of unnecessarily rigid, supporting providers who are transitioning to telehealth to figure out workflows, skills where needed, technology where needed, and then some parallel work on the sort of on the consumer and client side to make sure that people have equitable access to internet or even to computing devices to make telehealth possible. And we've highlighted on this side just a recent report that possibly many of you have already seen out of the Behavioral Health Institute. They did two things. They did a really nice kind of summary of the flexibilities, both nationally and in Washington, that had been enacted related to making telehealth more accessible during COVID. And then they recently did a needs assessment or a provider survey in Washington that talked about how behavioral health providers were adopting telehealth and what barriers still existed. And both of those are available on their website. It's a nice resource to go look at. Okay. Third one we called out was supporting peers. This came out of largely out of a discussion with you all in June, and sort of a discussion around how peers, particularly in rural regions, can really help expand access, can really help make the workforce more locally based, can help in some cases diversify the workforce. So we called out this one as an area for potential activity. There's not a ton of great data on peers at this point. They are sort of newly, in terms of state data systems, they are semi-newly sort of recognized through DBHR, and so the data for them doesn't go back too far. The data that we're highlighting on this slide is from 2017. There was some legislation in 2019 that called for a report on peer programs in Washington, and to our understanding, HCA is currently doing a survey to learn more about the number of individuals served by peer providers and where they're working. So ideally, there should be some better data about that in the future. But this one was something that stakeholders for BHT had called out as a potential area for action, and it's also something that a lot of BHT's clinical partners are currently working on. So it seems like an area where continued work could bear some fruit. And then the last thing we pulled out is better workforce data. I mean, in some ways, this whole report is sort of a bit of a plea for better data. And to be honest, better workforce data is something that is maybe less of a direct area for regional level action. But it's something that came up in discussion in June and comes up a lot just around the consistency of data on workforce, the sort of comprehensiveness. So the table in here, when we were discussing this draft report in June, someone had pointed out that it's really hard to figure out which of these, this is Medicaid data for Medicaid enrolled providers, and it uses the provider enrollment data from Apple Health. And it is hard in this list to distinguish between mental health and SUD providers in some cases, but that's how the data come. Or, for instance, there's some other interesting limitations in licensing data. For instance, the Physician Licensing Board for Washington either doesn't publish or doesn't collect physician specialty as part of licensing data, so it's a little bit hard to distinguish psychiatric providers among physicians just from those data. So there's a lot of areas where sort of more consistent and better quality data would be really helpful for looking at supply and distribution. So that's one of the fourth sort of area for action that we called out. All of these, again, are sort of up for discussion and either nuance or edit. And that's what Sarah's going to lead us through a discussion of now. But we're happy, and if there's any questions on the preceding stuff, we'd be happy to answer those.
Thank you, Lisa, for sharing. All right. Now we get to the portion where Lisa and I do less talking, and we want to hear from you on this. So I want to say first that Better Health Together still has some dollars from the integrated managed care work. And really what we're hoping to do is this report is the first step in us putting some dollars and efforts towards addressing issues that are identified. And so really we want to make sure, first of all, that we are drawing the conclusions from the report that we want to amplify. And so, kind of the first question is the highlighted opportunities, those four that Lisa just discussed. are those the ones that we want to highlight, both from what you've had a chance to see in the report and from your perspective as a provider in our community? Is that what would be helpful? So just going back to those four. So any thoughts on, did we get those right? Please feel free to unmute yourself or put in chat. A quiet bunch this morning. If that does feel like these are the areas both where there's definitely room for improvement, and there is work currently going on that we could boost. If this feels right, I'd like to hear that as well, just so we kind of have so that we know that this is the right way to move forward with that executive summary. Thanks, Megan. I see in the chat, agree with the highlighted sections. Thank you. All right. So the next question here, and actually I'm going to just ask folks to put their responses in the chat first, and maybe that'll help us get some a little discussion going here. Is among these four areas, if BHT were to put some dollars and focus together, where would you want us to focus our efforts? And I want to point out for number 4, for better workforce data, we're also curious to hear just if there are workforce things generally, not just data, that we could be doing. So I'm going to pop this question in the chat. And then if you guys could take a minute just to type in the chat where you think that we should focus our efforts together based on these 4. Thanks, Claire. All right. Thank you, everyone who's written in already. Just go ahead and continue if you haven't already. Really consistent, everyone across the board so far in chat has mentioned number 1, addressing access to disparities by race and ethnicity. And then a fair number, over half also mentioned number 2, maintaining recent expansions to telehealth for behavioral health services. And someone mentions that is complementary to addressing access disparities. And also some mentions for number 3, supporting peers, and number 4, around workforce data. We have a question from Mary at Children's Home Society. She says, I'd be curious to know what others are doing to support staff who are providing virtual services via telehealth. I worry our team is starting to become burned out. Training to support that would be helpful. So if anyone has any thoughts on that, or and if you do, if you can just mention in the chat and I can get you in touch with Mary, or you can mention what you're working on, that would be great. For other folks also starting to feel that telehealth burnout from their providers. Are we feeling all burned out this morning already? Pammy says, second what Mary says, our staff is becoming increasingly fatigued from the emotional labor of telehealth. Thanks for sharing that. And I'll say from Better Health Together's perspective, we are happy to bring in training or support or shared learning as part of our training series. If anyone knows of anything that would be helpful. Yeah, Linda, feeling the virtual burnout for sure. Some of this is feeling not as real as when we get to see people in person. So. Megan from VOA says, I've been thinking about the availability of telehealth. A couple of thoughts. Curious about strategic placement of computers for telehealth in different areas, such as libraries or medical offices, in order to increase access to providers that may not be as available due to region, COVID, etc. And Pammy says, please don't make it focused on self-care. We know how to do that already. So the distinction there being how to do telehealth in a way that feels more supportive to partners and patients. Is that what you're getting at there? Gotcha. Building resiliency to manage the fatigue. Thank you. Great. Well, if anyone has suggestions around training, and please let me know. Just email Sarah at Better Health Together. And I'll take a look around that too. So as we're looking at what the votes we heard from this group around the highlighted opportunities, we had 8 votes. Everybody voted for number 1, addressing access disparities. 5 votes for number 2, around maintaining recent expansions for telehealth. And I think it'd probably be fair to add the work to address the access issues there in terms of broadband and access to technology. And then just a couple of votes for numbers 3 and 4 at this time. Colleen mentions that there's a 1-hour training tomorrow, crisis leadership and resiliency, a trauma-informed approach to COVID-19 response. That sounds very relevant. Colleen, if you could email me the details or link to that, I can send it out to this group after our meeting. All right. Thank you, Colleen. Gail asks that wondering if there's any information about how those who are receiving their behavioral health services via telehealth are satisfied with this mode of service. Is this one of the areas that HCA is working on?
This is Lisa. I'm not aware of that, but it's a great question. I imagine, well, I don't know, we could ask around. I don't know that this is something HCA is currently working on. I am guessing there are various research groups that are working on this, but probably, you know, specific to a set of services or a set of providers. I can also circle back and see if Behavioral Health Institute has anything on that, or if they might know if someone is planning on doing that work, particularly related to behavioral health providers.
Thanks, Lisa. Yeah, I haven't heard anything, at least from HCA or Washington State level yet. So,
I will say there are over the last sort of 3 to 4 months, there's been any number of kind of grant opportunities looking, from government funders or from foundation funders like Robert Wood Johnson and others, sort of saying, wow, people, please do some quick turnaround research on the impact of COVID-19 on healthcare utilization and experience of healthcare. So I can imagine there's a lot of stuff that will come out, but those kinds of things tend to be kind of 18 months or 24 months in the execution. And if you're interested in more current data that's actionable, that's a really good question, and we'll try and follow up.
Yeah, Gail, some additional support in your in the comments for your question as well. Yeah. And I have another one mentioning number 2, and that those gains are something we need to keep going after COVID. But I'm curious, since number 1, addressing access disparities, it has come up kind of as the top vote for this group is around where we could put some collective efforts. I'd be curious from you guys, where do you think you would start with addressing those access disparities? There's a range of work already happening, but curious to know what gaps you see, or are there efforts that we should focus on around connecting folks? So just thinking about this, if number 1 has emerged, the addressing access disparities by race and ethnicity, where would you start the work, or where would you put some additional support or efforts there? Giving folks a minute to think and put thoughts in the chat. And of course, at any point, if you're tired of hearing my voice reading your text, you're welcome to unmute and just share by voice. And if we don't have thoughts necessarily where we would start addressing this issue, I would be curious to hear why this is the top one for folks. Hallie mentioned some race and ethnicity concerns are related to distrust of the system and providers. This brings in the increased use of peer supports, and I would say culturally specific approaches to build the trust and engagement via outreach. Great point, thanks. Other thoughts on things we might do to address access disparities? And they could be just wild, off the wall kind of ideas too. It doesn't have to necessarily be something that we could start tomorrow. Linda from American Indian Community Center says that I find that my community has major technology challenges. Linda, is that having the technology, or the knowledge of how to use the technology, access to equipment and internet. Thank you. And Claire mentions that transportation is a major issue as well as connectivity issues. So it sounds like in some ways combining numbers 1 and 2 may be a good place to start with some of this work, as well as looking at transportation issues in the communities. We also heard during our last discussion and follow-up that lack of culturally specific providers in the region has been an issue. And so I wonder if there are ways that supporting workforce in some way to get more culturally specific providers is something that would be a place to start, or if anyone knows of initiatives that have worked around that. And actually, Ron just says workforce shortages and how to invite people into the workforce to address some of those barriers. So thank you, Ron. I'd be curious to know if any of you are already doing work around these issues, whether it's ways to get internet access or technology to your patients, if it is transportation things that have worked, if there are ways that you've been able to invite folks into the workforce or help support them through their education or training. I'd love to also hear things that have been working that maybe we could support. Well, let's maybe focusing on workforce for just a second here. I've actually gotten this question directly from Allison, our executive director. She's interested to hear from your perspective. Any thoughts or ideas or suggestions of ways that we could continue to help support our region and the workforce issues here? So just to focus for a minute on the workforce and including but not exclusive to the culturally specific care, thoughts, ideas, suggestions of ways that we could support workforce issues.
Sarah, I would be interested in finding ways to support more peer supports and or recovery coaches in the field. And then along with that is the training for the supervisors, because I know there's specific training I would have to be able to have a recovery coach in the SUD program at Partners.
Great. Thanks, Colleen.
One thought I have, if I may, I think we all need to be vigilant on what DOH is doing. I think they're trying to do some innovative things to try to help get people into the workforce. But as we talked about, I think it was about a month or so ago, that doesn't necessarily relate well to being able to bill Medicaid. Those systems don't always match up well. For example, like with peers have a very narrow group of things that we're able to bill for. And so we all need to play well together.
That's an excellent point, Ron. Hallie mentions that there tends to be a high burnout rate, particularly in SUDP, possibly employer trainings to better support counseling staff. That's a great point. I mean, burnout is a huge issue for behavioral health workforce. Carly, can you talk a little bit about your comment around documentation and tracking of workforce?
Sure, yeah. You know, I just put in the chat, I feel like in my sort of landscape analysis and research to develop portions of that section, I came across a lot of complexity with regards to how certain care team members or roles are designated, credentialed, tracked. And I can imagine that that then presents a really difficult you know, value statement or case making around specific roles and needs for more roles if we don't have the sort of baseline data to demonstrate that need. So I just wonder if anyone has thoughts on whether or not that aspect of workforce is a challenge in your region.
Thanks, Carly. Any thoughts on that from folks? Has anyone had issues before trying to make the case for more types of specific types of care team members for specific license types just based on a lack of data? And if you haven't, if that's not a specific problem, let us know too, so we won't pursue paths that won't be helpful to you. Question from Katie. Have we learned anything more about the new billing codes or Siri? No, not yet. When I checked a couple of weeks ago, we still didn't have a 2020 Siri. So, but if anyone else has heard since then, that would be great to know. I think Hallie says it was on yesterday and saw nothing new. So we may get the 2020 Siri in 2021. I know there have been some issues that they've continued to work through trying to get the legislative changes from last year into that. So. Dave from Spokane Public Schools mentions that one of the problems he's had around workforce has been the time it takes to get a new graduate or someone moving new into the state to get them an active license. Yeah, the time frame for that can be, that would certainly be an area for potential policy advocacy or change. Let's see, Lisa or Carly, do you have any other specific questions for this group around the areas that have come out of this report or anything else around the report? Oh, and we have a comment.
I was just having a, I'm not sure the name, and Thomas, I'm sorry, I'm not tracking everyone's name on that, raised an interesting point in the chat about access to translation services. I think possibly meaning also like interpretation, not just written translation, but live interpretation, and how that's a barrier, particularly around the cost. And please jump in if I'm messing up your words here. but that Medicaid does not apparently reimburse for interpretive services in an inpatient setting.
Nicole says that's correct.
Thank you. Sorry, Nicole.
Both correct and it feels wrong, and from a what they should be covering perspective.
Yeah, it seems odd. I did something else that kind of came up in the chat that I just wanted to ask about. I just need to find it again. Possibly, oh, maybe it was a issue around, making sure if there's workforce innovations, interesting training, new roles, flexibilities that are sort of somewhat on the DOH side, and the really good point that it's not as helpful to develop all those flexibilities if the workforce that you then create and recruit is unable to get paid for their services. I've forgotten who brought that up, but the example was particularly around Medicaid billing. How much, I feel like we focus a lot of our advocacy a lot of times around workforce billing on Medicaid, around behavioral health. How much is this an issue on the commercial carrier, private insurer side, or is that just in general not the population that the majority of BHT partners end up seeing, and so it's less of an issue? Was my question not very clear? Sorry.
Yeah, if you just rephrase one more time, people might be thinking and typing too.
Just
Hi,
wondering whether, oh, go ahead.
I can answer just from our agency. So we are primarily around 85% Medicaid. So we're primarily Medicaid-based funding as our source.
Okay.
And who is
That
that
makes sense.
calling
Okay.
in? You just answered.
It's Sarah from Daybreak. Hi,
Oh.
Sarah.
Thanks, Sarah. And Dan mentions in the chat 95% of who they serve are Medicaid. Nicole, 99% from New Horizon.
Okay, that's helpful. Thank you.
All right. Nicole mentions 99 also. Wow, yeah, so it looks like in the chat, partners, Spokane Public Schools, Children's Home Society, all 90+% Medicaid.
Okay.
So in some cases, all Medicaid. Dan mentions that rates for private insurance are substantially higher than Medicaid and could attract more workforce with higher wages if we serve the well-insured, but that doesn't fit the mission. And speaks to an issue of Medicaid reimbursement rates as well.
Sarah, I noticed in the chat, I think Nicole was raising a sort of idea around, back to the workforce thing, about tuition reimbursement for behavioral health programs, or some form of it to make the career field more accessible. I don't know the landscape in Washington as well on this, but there's any number of sort of workforce incentive provider recruitment kinds of programs. Some of them are federal, sometimes there are state ones. I wonder, are there any, and often there are some local ones or, provider system specific ones. Do folks do any of that already? Maybe in the form of tuition support for people who are already employed, but are maybe interested in a higher or different level of training?
Some comments around that. Chaz has a tuition assistance program for existing employees. Excelsior has a scholarship internally. Colleen says she loves the idea for tuition reimbursement to include SUD. Have not seen a lot of forgiveness programs for, have seen a lot of forgiveness programs for mental health, but not many for SUD. STARS provides for full-time staff and are grateful for BHT grants. Dave asks, what do you mean by a higher level of training? So that might mean for maybe for someone to get duly licensed. I don't know, I suppose any kind of continuing education might be around that. So.
Sarah, this might be a good opportunity to bring up your program now currently to support folks at Spokane Falls and at Eastern trying to obtain dual licensure.
Yeah, thank you, Ron. So Better Health Together is working with Eastern and Spokane Falls to fund providers with our existing partners who are interested in getting dually licensed. So to go through the SUDP program at Spokane Falls or Eastern Washington. So we are offering financial assistance for that. We still have several spots available. So if you have a provider who would be interested in that, please let me know, or Charisse is in charge of that program. So email Charisse if you have even the smallest inkling that you might have a provider who would be interested, because we are funding that. Katie, do you want to, since you're on with us, do you want to talk a little bit about the program at the Falls?
Sure. So we're running it actually through our continuing education program because they can do that cheaper, and they're working directly, with you guys as well to offer that to some of those students. And the alternative training program, basically is doing it with 15 credits that certain advanced professionals can take those 15 credits. And I believe they're starting in the fall, and they're doing, I don't have it in front of me, but I believe they're running, I think it's going to be over 3 quarters and 5 credits per quarter. Don't quote me on that. And so that's for, of course, the licensed people, or people working towards their licensure. And it's also going to be working towards taking the NADAC exam. And I know that with Better Health Together, you guys are working, I'm not sure exactly what the financial piece there is. So it's working with Sandy Harper through our continuing ed. And so last meeting we went through and talked about the whole different program. I'm not sure if you guys can maybe resend out all that information. And then the other piece that Grace, and I don't want to speak for Grace, but I'll try to do the best I can. What the state has done is they are also now offering, it's a 60-hour training, and for also advanced professionals. And what we're kind of waiting to figure out, and Ron, maybe you can help as well, is talking about what the SERI billing is how and which ways you get your advanced professional licensure and how that's going to work with billing. And so those are some of the pieces that we're kind of waiting to see how that falls out. And so, but both, so Eastern's offering the 60-hour training. And so I have some feelings about, 60 hours of training in order to be an SUDP, but as well as the 15 credit alternative training that's being offered at the Falls. So.
Thank you, Katie.
Mm-hmm.
Yeah, I really appreciate you bringing up the point around billing, that the training program does not guarantee that your Medicaid contracts with the MCOs include reimbursement for SUD services. So that would be something that we just want to, every time that we can mention that it's not just about bringing new services on by bringing in new staff with those licensure, it's also making sure that it is within your contract to be able to bill that, even if it is a billable service on your Medicaid. If it's not in your contract, they may reject those payments. So just want to mention
and that's where the 15 credit it actually becomes an SUDP, which for sure is billable. And so that's some of the differences between the two. And so,
yeah. Thank you.
Yeah, part of the issue, if I may, KD Steele and I were meeting with James Cheney from DOH, and I posed the question about the new endorsement, that new co-occurring endorsement, which will be a product of Eastern's program. Sounds like a great opportunity. However, until we see the 2020 series, we don't know if that is a billable service, because currently you have to be an SUDP or SUDPT in order to bill an assessment, period. It's not negotiable. And so, as you said, Sarah, there's no guarantee that just because you have your shiny new endorsement that you just received, that you'll actually be able to bill Medicaid with it.
It's definitely a barrier there. Thank you for that point of clarification. We have a couple of great points in the chat around interest in pursuing the SUDP program, but would not have the supervisor or supervision support at their particular organization, and perhaps an opportunity to brainstorm a little bit to see if there's some kind of outside the box approach to form a cooperative, or to share supervision support. Supervision is certainly a bottleneck for some of the additional training. So I want to see if there are any folks who have taken an approach of having, working with other organizations to provide supervision, and have done that successfully, or other ideas around some of those supervision barriers. And if not at this point, maybe that's something for us to kind of work on together in this group, is if there are some opportunities to share supervision support across organizations that we could help facilitate those conversations.
this is Katie again. I'm trying to get Grace on the call if I can right now. She might be able to add a little bit. I'm not sure if she can make it or not, but I'll do my best.
All right, thank you. All right. Well, any other ideas or thoughts or concerns around workforce, areas for opportunity, particularly if there's anything around workforce opportunities to decrease disparities for race and ethnicity access issues? Just a call for any other general ideas around workforce at this point. All right. So the last question I had for discussion today is, we're just curious about your ideas of where we should share this report or portions of this report that might be helpful. BHT, of course, will share it to our whole partner list, but other areas where, or folks you think we should share with. So. And on the workforce, Dave mentions question that he has is, can past experience, grandfathering in, or other approaches be used rather than going back to college courses? That's a great question. I think that would take some pretty significant policy changes to be able to do that. Just because it frequently links that kind of needing to have some kind of certificate in hand to being able to bill, at least in our state. But definitely something that maybe is a long-term something to advocate for or start taking a look at. On the question of where to share the report, Hallie says that there's a COVID equity group at the health district. Not sure how expansive their work is regarding behavioral health, but would be a space to share. Thank you, Hallie. We'll make sure that gets to the health district folks. Other places that the report might not reach when we send out to our group, but you think we should reach out to? Mary asks if it's can share with the American Association of Critical Care Nurses. Yeah, absolutely. We will, so since we're not hearing any changes to the executive summary findings, we will remove that draft watermark there and share out with the group, and you are welcome to share with whoever you know or think might be interested in this information. So. And Ron mentions that we should know by January if DOH moves forward with a behavioral health bachelor credential. That would be great. Sharing the report with local government, Workforce Development Council as 2 suggestions. And if there are any lobbyist groups that could benefit from this information. Excellent. To share with the higher education and community colleges, absolutely. Great. Well, thank you guys so much. I want to check with Lisa to see if she has any other questions or thoughts from the group. And then also to see if there are any last questions or thoughts that folks want to share with us.
This is Lisa. I don't have, but this is a really great discussion, and I love all the specifics that have come up in the chat and from people's comments. I think there might be a good opportunity just to tweak that executive summary a little bit with some of the more concrete ideas that have come up here. Not to say that this is the one and only idea, but just sometimes offering that specificity can help ground a broad goal like address racial and ethnic health disparities, which is clearly something that needs to happen, but it can be sort of hard to get your head around. So I really appreciate this feedback. And I just want to say also that we really appreciate the feedback from BHT partners and you all throughout the process of putting this report together. Neither Carly nor I are behavioral health experts. And so, you know, we're good at sort of synthesizing stuff and finding bits of data, but the guidance and reality check from folks who do this work is immensely appreciated. And we appreciate your patience with us in doing this and letting us work on a fun and important topic.
Thank you so much, Lisa. And thank you everybody for the discussion today, your thoughts, your ideas. This is, as Lisa mentioned, we are not behavioral health providers. we're conveners, and so really, really appreciate you guiding where this is going. So just a last call for any thoughts. I see Hallie mentioned that, just to mention that we still, the supervision issues, and that they have a licensed professional that could provide services if supervision were available. So it sounds like that discussion maybe is something that we want to have at a future behavioral health forum around getting some creative ideas, vision and workforce. Any other last Last thoughts, suggestions, just happy thoughts to share on this Wednesday. Right, and if not, I will release you a little bit early. We'll follow up by email with some information about the SUDP program and the training that Colleen mentioned earlier. And with the final report here, probably in the next few weeks, and please share as widely as you'd like. So thank you guys. Everybody stay safe, stay cool. The weather's breaking tomorrow, and we'll talk to you soon.
Thank you, Sarah.